Bang on.
Okay, we are caught, so we're going to move on. Item 122, biannual safe staffing report. We've received reports. Lorna, your chief nurse, I suspect, is otherwise engaged, which is not in the room. So can we hand over to you, Lorna? Is that okay? We've had the reports. That's the key headlines and things you want to convey. And it's been through quality committee, I believe, as well.
It has, yeah, thank you. Yeah, it's obviously take it as read. Covering a few highlights really. Obviously, it's the triangulated staffing review covering the NQB guidance, and we use two tools within the trust: the Safer Nursing Care tool and the Community Nurse Safe Staffing tool. Within this report, there are no requests to change establishments, so all the reviews have been done with all the care groups. The rationale for that is around the reconfiguration of services across the three main sites, and the requirements to change establishment as a result of that was felt to be a big enough transition. So they'd like to do further data collection before we do any further establishment reviews more formally. CNSST tool is being reviewed. We've got a new tool, CNSST2. So the team are just going to data collect with that in January. They've just collected with that in January, so we'll present that in the July paper. Just to note, in the forecasting section, you can see a large gap within the registered nurse staffing prediction compared to the staff we predict to be in post. Just to kind of provide some assurance around that obviously the establishment is at a fixed level, and we anticipate that establishment will be reduced with the reconfiguration work, so the gap will not be as significant, and then we'll work on a recruitment plan once we know the predicted establishment requirements. The only other things to note are really that we've included this time in the review the model health data against the trust data for benchmarking in the national and local context section of the report. I'd like to just highlight the reduced demand hours filled by bank, which has been a significant improvement from 8.6 to 6.3%, and the 0% agency usage. I'd just also like to highlight the increased fill rates below 85% for support workers that we've seen for the last 6 months. We have held some recruitment events that have been successful at the latter end of last year, which should correct that. And we are anticipating to do further events this year to support our support worker recruitment.
Brilliant.
Happy to take that.
Well, that was really, really clear and well described. So thank you for that. I'm going to initially ask Alison to respond, and then we'll open up to further questions.
Yeah, I think what you see here is the triangulation between the IPR and the biannual staffing review as well, which is really helpful. And I do think that we need to recognise that probably will be a requirement next year for us to do some element of international recruitment because the domestic supply line that we've identified is going to be a shortfall regardless of the reconfiguration activities that might then result in a reduction in the establishment. So just really for board awareness, I think there will potentially be a requirement for us to develop that business case during the course of next year.
Thank you, Alison. Sarah.
I just wanted to note that we're also looking at our apprentice business case as well, because the current one will end in 2024. So we're just mapping how that may look for 25 onwards, focusing on how to recruit to posts rather than the adult general posts that we've recruited to in the past through apprenticeships. But definitely there'll be a need for the apprenticeship and potentially some IR recruitment. We'd prefer the apprenticeship model because it's more sustainable, grow your own, and we anticipate that NHS England will potentially support with funding some additional apprentice. We are seeing more money coming for apprenticeships as well, so we hope that that will be a more sustainable option.
Totally support that about the apprenticeships. We've got a good track record as a trust. Sarah.
Thank you. So confirm we have received this as well as the monthly safe staffing reports that we received as a committee. There's one thing I wanted to add, and then I wanted to ask Lorna to talk to a little bit more, if that's okay, Lorna. So I think we've discussed before around whether there's a model for allied health professional staffing. If I can answer the question, that's good. So we discussed that at the Quality Assurance Committee in the context of this report, and the position at the moment is that there isn't a model currently for that, but that demand and capacity modelling for out of hospital care is currently being undertaken. I think that might be across the system, and other colleagues obviously listen to that. But sorry, this was I understand it. So that's a response to that question. That Karen didn't ask, but I asked on her behalf. And Lorna, I just want, we've also noted the inclusion of the model hospital data in the reports, which has been really helpful, and we can see we're a positive outlier in a number of places. And colleagues may look at this, for example, page 301, and consider we're a negative outlier in terms of our care hours per patient day. And that's something we have interrogated, I guess, or asked questions around as a committee. And I just wondered, Laura, rather than me trying to say what that means, I wondered if you could just talk to that a little bit in terms of, we look like an outlier, what does that mean for our trust?
Yeah, so care hours per patient per day were obviously generated following the Carter report around how we benchmark services. I think, unfortunately, a lot of the data is discussed at a trust level, and we present it in that way as well, because we, for want of a better system, really. In the monthly report, we do break it down by individual department, and really the value of care hours per patient per day are when you compare two like for like departments to understand if the care hours per patient per day are comparable. So actually the trust figures sometimes are a little bit misleading. So we do look in higher, we're in the fourth quartile, so that is kind of unavoidable as a trust. I think the thing that we are looking at is that vulnerable model that we have around small units, which sometimes increase our care hours per patient per day, because the way we have to run them with the staffing that we would require, even for a small unit, it becomes, the care hours become incredibly high in those areas compared to a larger unit in a larger single-sited trust, for example. So we have to kind of use the data carefully and not make too many assumptions from the trust level data, really.
Okay. Ali, and then final question from Ali, and then I'm going to move us on if that's okay.
So this was just also to triangulate that this was picked up as part of the PwC work, as part of the grip and control assessment, and that information has been shared back with them, and there was no further response back from them in terms of potential additional benefits that we could get from a financial perspective aligned to care out our patient name.
Right. Thank you very much, Lorna. Much appreciated. Just in terms of recommendation, so there's two parts to this. First, which we've done, consider the proposed safe staffing reviews of all care groups and resultant changes to staff and establishments, respective financial implications, which just touched upon. Where there is a proposed increase in cost as part of this review, care groups will be required to provide a separate business case for approval. And then the second part was for us to consider the context of these requests in terms of fill rates, vacancy rates, sickness rates, staff turnover, recruitment plans and temporary staffing arrangements highlighted in Appendix 1. So we've done that, I think, quite well. It's gone through the Quality Committee, so are we happy to support this report and recommendations? We are. Thank you very much again, Lorna. Much appreciated. Chief Exec is temporarily out of the room, so I'm going to move to item 124. And Sarah, that's the update on the Quality Governance Assurance Framework.
Thank you, Chair. This is essentially just the mapped meeting structure that's already been through board and that we agreed at Quality Assurance Committee. But I don't think there's anything to highlight.
I would agree. Are there any comments from particularly Ned's? Thank you.
Thank you. To confirm, yes, absolutely. What I did want to draw colleagues' attention to is the inclusion of the proposed health inequality metrics within that report, which is something that I know non-executive director colleagues have been asking for.
So to flag that, if you access the IPR on the database, the metrics are there. So, and they have been there for some time. It's just when it's not included in the paper IPR. That is slide deck that we send, but it is available should people choose to access it in the online version.
Sarah, okay.
So I think what the colleagues would be looking for, and I don't want to speak on behalf of it, is assurance about what those metrics are telling us in terms of patient experience and outcome. So we perhaps need to think about this, how we can bring that through more visibly.
And linking in with Craig, who's also not in the room, to about how, and that was a conversation he and I had about increasing that visibility at boards, because obviously understanding that accessing it online is something more difficult and requires more steps. So how can we increase the visibility? Thank you.
Okay, Nicola, you're on the screen. Your hand is up.
Yep, thank you. Just in support of the comments being made there by the Chair of Quality from conversations we've had in finance and in audit, I would say yes. While we know the data is there, I think it's the commentary that accompanies that data that we would want to give the relevant, lead officers the opportunity to be able to provide that commentary so that non-executive directors are interpreting it appropriately. Thank you.
Okay. So let's, Karen, last question with Karen and we'll
Okay.
move on.
Last one, and Sarah, forgive me if it's there, but I know one of the things that I'd highlighted was just our ability to see services and impacts on outcomes for children in the data, and recognizing it's a small part of our business, but an important one. And it's just being assured that that will be, we hear it through safeguarding, so we had a really comprehensive report on safeguarding, but it's other outcomes that we are less able to see.
So I'm leading the divisional due diligence piece of work, and there is an enhanced governance structure around CYP, which is reflected in that paper, which is coming to board next time.
Brilliant.
Lovely, thank you.
And I know I said last question, but I was very rude because Tabitha had a hand up and I didn't catch it. So Tabitha,
I'm sorry, Chair, it's not a question. I just wanted to give apologies on behalf of the tribe, the colleagues who are missing. They're really tied with the RLI, so.
that's not a problem.
Just-
We
just-
aware of that. That's not a problem.
Yeah.
So there were a couple of, thank you, Tabitha. So there were a couple of items in terms of conversations offline, in terms of the well-being and the issues around children and the visibility around assurance in terms of the measures, etc. So those will be taken offline, and Sarah, as our interim director of governance and assurance, will kind of be the lead pinch point for that. In the meantime, we're asked to that the board is advised on the updated quality of assurance, and we're satisfied with those, which I think we are. It's very welcome. So thank you. Brilliant. Thank you. Back to item 1, 2, 3, the provider collaborative update. Chief Executive.
Yeah, thanks, Chair. So a lot of work going on in the collaborative space at the minute, both on kind of finishing the year, but also planning for next year. So you'll see in the document some of the good work that Chris has been leading with the finance working group on an approach to, call it the 1LSC way, being really consistent in the way that we're planning kind of financial improvement, financial reporting, some of that financial discipline. Is now playing out in the system. So that's been a big piece of work that we've agreed with Provider Collaborative to get a consistency of approach. There's also some good reflections in there, I think, of the work we've been doing, particularly around elective recovery and cancer improvement. You can see we don't often put the benchmark data in here, but sharing the improvement work, sharing, I guess, demanding capacity kind of conversations across the providers means we're able to improve performance for elective recovery in our patch more than the other patches in this part of the world, which is good to see. We have just started a piece of work building what we think next year's delivery plan will look like. It will include those programmes that we are familiar with, Chair. So 1LSC transformation programme, pathology, consolidation with the collaboration arrangement, our progression around digital innovation, particularly around that EPR convergence, and the work that we'll take forward on the clinical strategy. Some of those will be programmes we are aware of now, vascular, head and neck, urology. I'm just putting a team together to look at what we're doing with the Strasis proposals for next year and what that might be in terms of clinical strategy development. At the moment, there's value in the provider collaborative schemes at around 35 million for next year, 42 million for the year after. I've asked Jonathan Wood as the managing director to work with the COSEPs on bringing some of that a little closer to us, so we understand the value of the collaborative and what it's delivering for the system. I've also asked the COSEX to bring forward in the next cycle the forward plan. So this board is clear as to what decisions are likely to be made next year in the collaborative, and that we tie in our own governance process to ensure through the assurance group, we've got that connection right. So motoring a little more purposefully, I think, than we have done in the last 6 months, rightly. But yeah, we should see more in the delivery plan focus next month.
Thank you, Chief Executive. Nicola.
Thank you. Just one comment, and thank you very much for that, Aaron, is in relation to the digital strategy. It's just the opportunity to understand what might also be our strategic objectives above and beyond the EPR that help us to move towards that ambition of place-based, community-based technology, addressing flow, addressing sort of collaboration between different actors on a patient's journey. Thank you.
Yeah, I'll bring Ali in a second. So just from my update that Nicola, that's purely what's in the purview of the provider collaborative, which is EPR convergence. I'll hand over to Ali, who's going to articulate what we're doing strategically around digital innovation, particularly with our board, but also in the system. But very specifically for the PCB, it's EPR convergence, which is in the mandate.
Thank you.
Yeah, so there are kind of 4 strategic priorities for next year for us from a digital perspective that we are taking into the exec team to ensure there is kind of cross-portfolio commitment to those programmes, and they will then be overseen through Tim, Nicola.
Okay. Look forward to hearing about them. Thank you.
Thank you, Nicola. Okay, colleagues, so we're asked to note the reports from the Chief Executive, which we've done. So I'm going to move us on to item 125, which is again with Sarah Hoxwell in terms of the NHS oversight framework, etc.
Thank you very much, Chair. So you'll be aware that we agreed our soft 3 exit criteria with the ICB in last year, and we have been monitoring our progress against these. At the moment, the most significant thing that is preventing us moving to soft 2 is around our financial position, which has been detailed and discussed earlier. In terms of a quality and safety issue, it triangulates well with what's already been picked up around pressure ulcers and around the VTE performance, and around our fractured neck and femur alert. Other than that, we are performing in line with the soft 3 to 2 criteria, and the ICB have articulated that whilst we are narrating certain quality and safety issues, they are within their tolerances.
Okay, thank you, Sarah. Are there any comments in regards to what Sarah's report? It's a really, as Aaron said before, it's a helpful and really clear piece of work. Obviously, it's when eventually we'll be able to move into that position of moving forward around soft 2, but we'll navigate the landscape for a little while longer. So the recommendation is that the board of directors be advised and deliver against the exit criteria, which is in the report. We've looked at that and we've considered it in light of the comments made previously in the board. So I'll move us on to item 126, which is the BAF 24-25 company secretary.
Thanks, Chair. So in receiving this report today, the board is asked to note that there are no changes in the scores proposed. However, we are carrying an elevated level of risk in respect of assurance risks 2 and 3 relating to kind of finance and people and use of resources. Can confirm that there has been ongoing oversight and assurance through the trust governance and assurance frameworks. We've got a narrative on pages, I think 339 onwards, which gives a little bit more detail around that. I'm not going to repeat that today, Tony. Yeah. It's kind of a confirmation and triangulation of kind of the various updates that you've had through your IPR, your 3A's reports and other reports on today's agenda. Just a couple of things that I do want to draw your attention to. We've done a lot of work around financial governance, and just so that the board is cited on that, we've appended a schematic which shows that new enhanced governance framework, and it's important that the board is cited on that. In terms of BAF risk 4, we just want to cite the board on what we've heard earlier today about system oversight level 4 in terms of support that other colleagues. What will be undertaken in the next period to understand how that's going to impact on our partnership work. and joint working arrangements, we anticipate that there will some impact, but it's too early to say, but we need to do some diagnostic work around that. There are some other issues included in the covering report that we're going to close off in terms of kind of governance updates. The only one that I would wish to kind of highlight is the actions which have been undertaken in respect to the new hospital programme. Whilst disappointing that we had a delay in terms of when construction might start, just to confirm that a dialogue continues with the new hospitals programme team. I just want to respond to the point that Karen raised before.
Yes.
I'll answer that in two parts. Following the discussion at People Committee, we recognise that Ali's a member of the Finance Committee, so for the remainder of this year, we've got that connection, which is something that was discussed at the People Committee. But that does then talk to something that we're going to speak to in private agenda today, which is what does the constructs of our Board of Students framework look like, what's going to be the pillars, the key areas of focus, and we'll pick that up as a discussion later today, Tony. Other than that, I would ask the board to kind of receive the report and the board reporting tools, but happy to take any questions that the board have.
Okay. Colleagues, obviously it's a process of reiteration, but in terms of the risk scores, where it is at the minute, it's gone to audit committee as well. Are we confident in terms of the content? Nicholas, chair of the audit committee, is there anything you want to add in regards to the paper that you had at audit committee?
No, we received the assurance we sought at the audit committee. I think the only matter that's arisen since then has been colleagues raising concerns about the fragility of the finance team under the current circumstances and where that might sit in our risk assurance.
Okay. Are there any reflections or comments from other people on board today in terms of this paper? No?
No, just accept to.
So yes, sorry.
Right, please carry on.
Yeah.
No, but yes.
It's just, could I suggest that for the conversation later?
Yes.
Board referred to, we also link into that how we might consider the potential impact and mitigating the impact of escalations in BAF 2 and 3 impacting on BAF 1. So it's how we, so yes, recognise that they need to be separate and considered in that way, but actually the impact on BAF 1 is something that's the highest priority, I'd suggest.
Okay. So on that basis, colleagues, I'm going for the recommendation that as board directors, we are asked to consider the contents of the reports, which we've done, and receive the board assurance framework reporting tool for January, February 25, which we've done. We've noted the scores, they haven't changed. And I think on that basis, I'm just looking for endorsement from the board that we're happy to proceed with this. Yeah, thank you very much. Item 127, Chief Medical Officer's update. Jane.
Thank you. So Anita, as you will all know, looks after mortality for us and is here today to present mortality.
Thank you.
Thank you, Chair. So this paper describes the process of learning from deaths, and I take the paper as read. I'd just like to highlight that on page 386, we've got 7 areas of learning from deaths. One is externally validated, and its called is quantitative, and that's the head data. And if I point you to the table and chart, which is on page 387, it shows that our SHME and HSMR remain green, and in fact those positions have improved in February, and that SHME has been in the position since October 2023, i.e. we're below 100, and HSMR has been below 100 since May 2022. We have an amber alert for fractured neck of femur, and had a slight reduction in February, but we're still alerting. So what are we doing about that? The head of improvement and redesign is supporting the trauma and orthopaedic team in terms of their steering committee and their working group to look at fractured neck of femur and improvements within it. In addition to that, we've had a letter from the National Hip Fracture Database lead, Will Erdley, externally, and Dr. Anthony Johnson, who look at the National Hip Fracture Database and have outlined that for 2 successive quarters, our 30-day mortality has been higher. So it's at 12%, whereas nationally it's just above 6%. So we are getting external support from them. We've acknowledged their letter, which arrived early in February, and we have a systematic action plan in place to discuss with them, and they will let us know when they are going to visit us in March to provide that external scrutiny and support. The other areas that we look at is learning identified by medical examiner scrutiny and structured judgment mortality reviews, which our mortality reviewers do. We had 10 cases of poor care, and the detail of that is in the paper. And just like to say 3 of those were in fractured neck of femur, and the trauma and orthopaedic team have reviewed these and have had learning from that, which has been shared wider than trauma and orthopaedics. We also, from the medical examiner scrutiny, we get feedback from the bereaved, which is very useful in terms of providing us a barometer as to how we deal with patients who are at the end of their life. The Learning Disability Mortality Review gives a great insight into those who are disabled and on the autistic spectrum, how we support learning from that, and that's been widely shared. The child death review process is quite extensive, and I'm not going to go into the detail of that, or the perinatal mortality reviews. All these are reviewed in the mortality steering group, which is held monthly, which reports back to the quality governance group, which then reports into the quality assurance committee. With respect to patient safety events, there's 3 that I've highlighted there, and one of them was went to the statutory coronial system, and we had a prevention of future death for a case of dissecting aortic aneurysm, and lessons have been learned with respect to that. I continue to push on improving care for the living by learning from those who have died in our care, and I'm happy to take any questions, Chair.
Thank you, Amita, and thank you for that. That was a really clear summary, really helpful. It's been through quality committee, so can I just maybe start with Sarah, just from your perspective, any reflections or assurances you can provide?
Yeah, I mean, first of all, Quality Assurance Committee really commends the report to the board in terms of the depth and quality that's within it, and what it tells us about how we are learning from deaths from a number of deaths within our care and from sources. And there are some positive, strong case studies in here as well, I think, in terms of how some of that's been looked after. Just to comment on fractured neck of femur, so of course we do continue to receive quarterly updates to Quality Assurance Committee, and actually when we reviewed this report in the last meeting, the additional ask we asked of the next report is that it includes the action plan that trauma and orthopaedics are going to put in place following on from those reviews of deaths from related to fractured neck of femur, so that we can see a bit more assurance around how that group is responding to these, given that's a major driver. So those are the key points I was going to make for the Quality Assurance.
Really helpful. Thank you. Are there any other points of clarification or questions from the board? No. Amita, again, thank you. Really great to have you here today. So the recommendation that the Board of Directors is asked to receive and that the contents of this report, which I think we have done, so thank you very much. Agenda item 128, Chief Medical Officer.
Thank you. So I'm presenting this on behalf of Cam, our Chief Pharmacist, who is the Controlled Drugs Accountable Officer for the Trust. So just to put in context, every year we have to put in a self-assessment. That's gone on for a lot of years. But suddenly at the end of January, we were faced with, you need to fill in your self-assessment this year. By the way, it needs to go past your board, which was a new requirement. And the date for it being submitted is the end of March. So unfortunately, it didn't really fall in very well with our board cycles. So Cam has worked with Paul to do what we can around it. It has been through our 2 quality governance meeting where we suggested some changes, and the overall ask of this board is that we delegate to quality committee for final sign off, as there's a quality committee next month. So however, all we have to do when we submit is to tick yes, no, partially, fully, etc. But we ask for all of the evidence to be itemised so that the board can see why we've ticked those things. And so the questions and the submissions are as given. We generally have got positive answers to all of those. There's a couple of areas where we can answer somewhat rather than fully, and we've got some actions there. So really it was an ask that we can delegate this to Quality Committee to sign off after further discussion.
Thank you, Jane. Just one question. Why has it come to the board? What's prompted it to be nationally prescribed as coming to the board?
We don't know. We don't know. We've not sort of. It's just been a new ask this year.
Right. Okay. Are there any specific comments or questions in terms of this paper? It's pretty clear cut, I think. So I'm going to go through these specifically, if that's okay. Receive the proposed self-assessment information, which we've done, which Jane's articulated as well. Delegate final approval to the Quality Assurance Committee on behalf of the board. Number 3, authorise a controlled drugs accountable officer to make the submission electronically for the 31st of March 2025. And finally, support the proposed improvements of a quarterly controlled drug 3A report to Quality Governance Group and an annual controlled drug compliance report to Quality Committee and then to board. So those are the recommendations, and I believe we are all supportive of those. So thank you very much, Jane. Much appreciated.
Thank you.
Agenda 129, Board Insurance Committee Terms of Reference. Paul.
Yeah, thanks, Tony. So this is a report to present the Board Assurance and Assurance Committee Terms of Reference and Schedules of Business for 25-26. The supporting information was set out by separate link. Just a couple of things that I want to draw that are covered off in the covering reports, which are, we've had previous discussions around the frequency of meetings, and we're now in a position where we're going to recommend that the Quality Committee meets on a bi-monthly basis. However, given the highlighted ongoing financial risk, we are not proposing to step down Finance Committee on a bi-monthly basis. That will continue to meet on a monthly basis. You will note that we have included the new hospitals programme. We believe there's a requirement for an additional meeting during Q1, but the intention would be to step that committee down once that meeting's taken place. Other than that, I'm happy to commend the report to the Board of Directors. It's been through all the different committees ahead of this meeting, but happy to take any questions if there are any, Tony. Thank you.
Thank you, Paul. Sarah.
Thank you. It's not a question, but I just wanted to sort of confirm the Quality Assurance Committee's support for the recommendation to move to bi-monthly is very much grounded in the metrics we've all talked about today, and the report Sarah's given about soft read too. So on the basis of that stability of the metrics, we are supportive of going to bi-monthly with an extended meeting length because of the size of the agenda, but we're confident we can maintain that, and if needed, we can stand up additional meetings.
Absolutely. Thank you for that, Sarah. Are there any other comments? Colleagues, no, I don't think. Karen, apologies. It's because
it's fine. It's fine. No, it's just linking back with the discussion earlier today about governance assurance and with regard to one LSC, and at an appropriate time when the work plan is come to fruition, that may need to be reflected in this. It's just to highlight that.
No, that's an important point. So noting that, I'm taking the recommendation, which is we're asked to approve the Board Assurance Committee Terms of Reference and matters delegated as per that report. Are we okay with that, folks? Thank you very much. Item 130, Chief Executive Policy. It says Chief Executive Policy and Publications Report.
Only two, Chair, in the document. One's around the planning guidance, which has been circulated for colleagues ahead of this. Just a bit of good news around FGH endoscopy services received JAG accreditation following its February review. So that's good. That's awarded for 5 years.
Okay, so we've noted the content of the Chief Executive reports. Last closing points of administration, attendance monitoring register. You've received that and is to note. Schedule of business, again, you've received that in your bundle and it's to note. Urgent business, I'm not aware of any urgent business.
Related to anything.
Date and time of the next meeting is there on the agenda. So, folks, before we rush off, can I ask the non-executives on the call to remain on the call, and for all our other guests, if they could, we'll say goodbye and thank you very much for your attendance and commitment at the meeting today. It's greatly appreciated. So if Ned can stand the call, everyone else can get on